notice, when the clinical signs are there, it is a very easy diagnosis to make, and the HSE guideline, you did accurately quote from it, you get on with care and you carry on with the pregnancy termination. But the point is that subclinical chorioamnionitis is a real issue. Patients often do not show you that temperature, do not show you that tachycardia, fast heart rate, do not show you foul-smelling fluid, tender abdomen, until much later in the course. So if you have a patient who's 14, 15, 16 weeks with ruptured membranes, she could well be developing that. She has virtually no prospect of getting to a gestational age where she will have a live baby, very, very small, yet brewing inside, without showing you any signs yet of clinical infection, there can be serious infection going on. So it is a real issue. Yeah.
Intervene at that point.
Absolutely, because the reading of the guideline is, you correctly quoted it, is when clinical signs are there. But infection can be there much earlier than the clinical signs, and that's the point. And you'll take that risk if the patient was 23, 24, 25 weeks, on the cusp of viability, and we might just get there. Fine, let's take that risk together. But when the patient is 14 weeks or 15 weeks, and she has another 10 weeks of this, before even starting a chance of viability, you know, that balance is just very hard to justify. So it does restrict us. You express surprise that some families who have carried a baby with fatal abnormalities to term and have had that those special moments after birth, that they would have a hard time reconciling the whole idea of termination for fatal fetal abnormalities. I completely agree with you on that, and I absolutely accept that there are some parents who follow that journey who would find what we're talking about appalling, and could never conceive an idea where they might terminate their pregnancy. But equally, there are many patients, when you tell them at 12 or 14 weeks that your baby unfortunately has no head, has no upper brain, and there is nothing we can do about that, but unfortunately you have to wait another 4, 5, 6 months before you can do anything about that, they would find that equally appalling. So what I'm here today is to tell you that we would like to care for all of our patients, irrespective of what their personal, moral, religious, ethical background is. And one group of patients currently has a care pathway that they can follow, but another group don't.
Thank you, Professor. Deputy Rabbit.